A través de los años, la comunidad CETYS se ha caracterizado por su solidaridad, capacidad de sensibilidad, su flexibilidad al cambio y por encontrar nuevas oportunidades para el crecimiento. Hoy, en vista de los retos que la contingencia de salud nos ha representado, seguimos juntos adelante hacia el mañana.
CETYS Universidad somos todos. En su 59 aniversario, nuestra institución crece y se construye gracias al trabajo de colaboradores, docentes, alumnos y la sociedad que a lo largo del tiempo han acogido este proyecto educativo y lo han vuelto suyo.
La contingencia de salud nos ha permitido afrontar una nueva normalidad desde la innovación. Damos continuidad a la educación integral mediante el modelo CETYS Flex 360, del cual me siento satisfecho por haber formado parte del grupo diseñador. La campaña CETYS Solidario, que a través de la conformación de un fondo ha permitido apoyar al alumnado más vulnerable ante las consecuencias económicas del COVID-19.
Hemos mantenido una salud financiera que nos ha permitido equipar de tecnología las aulas para el regreso presencial del alumnado, así como la adecuación de nuestros campus para un próximo regreso a clases presencial. Recuerden, ya los queremos ver. El proyecto educativo CETYS es por y para la comunidad. Es por esto que 8 de cada 10 de nuestros alumnos cuentan con una beca o apoyo financiero, gracias al compromiso de nuestra comunidad con los jóvenes de México y la región. Y para 2020 incrementamos el monto de becas en un 10% para enfrentar los retos de la contingencia. Ejemplo de esto es la beca Unidos. Nuestros 874 colaboradores y más de 900 docentes en el sistema CETYS nos han apoyado para que, inclusive en la contingencia, la comunidad deposite su confianza, teniendo como resultado a más de 8,100 alumnos inscritos en el 2020. Esto es un reflejo de la trayectoria de CETYS y su educación de calidad. A las madres y padres de familia, así como al alumnado, les agradecemos la confianza depositada, ya que ante la adversidad hemos logrado ser una comunidad sólida y unida.
Buenas tardes, sean todas y todos bienvenidos a este evento que está presentado por la Maestría de Gerontología Social y la Maestría de Neuropsicología de CETYS Universidad. Le damos la bienvenida a la doctora Emanuelle Pourcher, que se ha tomado el tiempo de venir a platicar con nosotros el día de hoy sobre los aspectos neuropsicológicos y psiquiátricos de la enfermedad de Parkinson. Enseguida le voy a dar la palabra al doctor Arturo Ron, que es coordinador de estos programas de maestría en el campus Ensenada. Es una conferencia que va a transitar casi toda en inglés, pero quiero agradecer antes de ceder el micrófono a la doctora Emanuelle. Docteur Emanuelle, nous sommes très reconnaissants pour votre générosité de vous avoir parmi nous pour partager vos connaissances avec nous. Bienvenue, doctor Arturo, cedo la palabra.
Muchas gracias. Pues agradecerles a todos por darse la oportunidad de estar aquí y pues sobre todo también a la doctora Emanuelle por acompañarnos. Antes de empezar voy a leer una breve reseña sobre su trayectoria. La doctora Emanuelle es especialista en trastornos del movimiento, ha sido directora del Centro de Investigación de Trastornos de la Memoria y el Movimiento de Quebec, en la ciudad de Quebec, Canadá, el cual es uno de los centros ambulatorios para la enfermedad de Parkinson más grandes de ese país, y ha tenido esta función durante los últimos 25 años. La doctora se formó en neurología en la Universidad Claude Bernard en Lyon, Francia, y posteriormente tuvo estudios de posgrado en la Universidad de Laval, en Quebec, y bueno, también completó estudios postdoctorales en epidemiología y genética en el Instituto de Investigación de Montreal, en la Universidad de McGill, y en investigación clínica en la unidad de investigación del Hospital Universitario Pitié-Salpêtrière en París. Ha impartido cursos de neurología y neurofarmacología en la Facultad de Medicina en la Universidad de Laval durante más de 30 años. Ha sido neuróloga en ejercicio, especialista en trastornos del movimiento en el Centro de Salud de Ciencias Neurológicas de la Universidad de Laval y en el Instituto de Salud Mental de Quebec durante los últimos 35 años. De igual manera, es miembro del Centro de Investigación de Neurociencias de la Universidad de Laval y científica clínica del Centro de Investigación del Banco de Cerebros del Instituto de Salud Mental de Quebec. Durante los últimos 25 años, pues ha participado como investigador principal en más de 80 ensayos clínicos, incluidos ensayos sobre medicamentos fundamentales para la enfermedad de Parkinson, y ha sido autor y coautor en más de 100 publicaciones científicas. Además, es miembro del Comité de Directrices sobre la enfermedad de Parkinson de la Federación Canadiense de Ciencias Neurológicas. Y bueno, esta función la ha tenido durante los últimos 10 años, además de ser miembro del Royal College of Physicians en Canadá. Y bueno, también tiene vasta experiencia en el ámbito de la neurología en Francia. Entonces, es un currículum bastante exhaustivo, como pueden ver. Esperemos que podamos aprovechar al máximo. Y bueno, sin más preámbulos, pues ahora sí, doctor Pourcher, vous êtes prêt? Oui? Ok. Si vous pouvez habiliter votre micro, s'il vous plaît.
Ça y est.
Oui, oui, perfecto. Ok. Ok, entonces, vous pouvez commencer.
Muchas gracias. Let's switch to the title of my presentation. I'm sorry, I am unable to do this in Spanish. I would have rather to make it in French, but we'll go with English. So it's a topic close to my heart, the neuropsychological and psychiatric aspects of Parkinson's disease. Next slide. The objectives of these lectures will be to approach the chemical and anatomical basis of the disease, Parkinson's disease, to understand the different biological, psychological, and treatment-related factors at play in the neuropsychiatry of Parkinson's disease, and finally, to address the presentation of this problem and some therapeutic specificities. So, what are the chemoanatomical bases of Parkinson's disease? We know from the beginning of the last century that it has a histopathological signature with a loss of dopaminergic cells in a part of the brainstem called the substantia nigra compacta, but also more recently we have discovered that other nuclei of the rostral brainstem are lesions also. The signature of Parkinson's disease is the Lewy bodies, which is an acidophilic inclusion in neurons before they degenerate, and Lewy neurites, the axons, can be signalized by the degenerating aggregates of a misfolded protein called alpha-synuclein. Next. The binding studies of synuclein by Brock in 2003 have allowed to determine an evolution of the disease and the lesions. The analysis of brains of patients or persons dead without the disease have shown already synuclein binding in the brain, and in the pre-motor phase of the brain of the disease, we define different stages. The premotor phase is defined by the Brock stage 1 and 2, where lesions, shown in pink on the schema, are mainly in the caudal part of the brainstem, in the medulla. And they are found mainly in the dorsal nucleus of the vagus nerve. They are found also in the olfactory bulb at the base of the frontal lobe. The Brock stage 3 and 4 show a caudorostral extension, progression of lesions marked by synuclein, and we'll see there some problems in not only the medulla, but also at the upper level in the pons and in the mesencephalon. These stage 3 and 4 define the motor disease, what we know as neurologists as the Parkinson's disease with tremor, rigidity, and slowness of movements. Stage 5 and 6 of Brock show an extension of the lesion in the limbic system, hippocampus and amygdala, and we can see also lesion in the neocortical area, mainly the associative, high integrative region of the brain. So the occipital and parieto-occipital regions, temporal regions, and frontal regions. So this type of histopathology showing synuclein lesions from the bottom to the top define the extension of the Parkinsonian lesions and define different stages where problems are different. Next slide, Arturo. We come back to the premotor phase of Parkinson's disease. Stage 1 and 2 of Brock, lesion in the olfactory bulb and the dorsal vagal nucleus in the medulla. The symptoms of the premotor phase that before we frequently encountered in the patient before the beginning of the motor symptoms are now currently followed in large cohorts to see the rate of what we call now phenoconversion from the pre-motor to the motor phase. We recognize that our patients have problem with the olfaction, either anosmia or hyposmia, difficulty in discrimination of odors. Constipation also. We know that the vagal nerve gives innervation to lungs, heart, and digestive tract. Problem with sleep, and a symptom which is now well recognized as a precursor of some synucleinopathy, the REM sleep behavior disorder. That means that the patient during his REM sleep, during dreaming, is enacting the dream with a motor behavior. But also depression, higher emotivity, and anxiety may inaugurate the Parkinson's disease. The motor phase is the phase of the neurologist and the starting of treatment with dopaminergic agents. Stage 3 and 4 of BRAC. Lesions are in the dopaminergic, but also in noradrenergic, cholinergic, and serotoninergic system of the brainstem and basal forebrain. The symptoms are motor, but also affective, cognitive. We'll see them. What we neurologists call motor and non-motor symptoms in a very gross classification. In that phase, symptoms are amenable to improvement through pharmacological intervention on the aminergic systems. Next, we have here schematization of the main aminergic and cholinergic systems. We are dealing with serotonin pathways. As you see, the raphe nuclei, sorry, I have no arrow. The raphe nuclei depicted in red here innervate the whole brain in long connection and collateralized axons going to the forebrain, but also to the cerebellum and spinal cord. Exact. Norepinephrine pathways come from a big structure in the pons called locus ceruleus, which is pigmented in gross anatomy. And the same mode of distribution than serotonin for norepinephrine goes everywhere in long collateralized axons to the neocortex, to subcortical structure, thalamy and striatum, to cerebellum, and to spinal cord. So the specificity of their message is ensured by different type of receptors and different modulation of their message through long and short circuitry. Next slide. Dopaminergic pathways here are of prime interest. If we can detail a little bit the type of dopaminergic nuclei we have. Substantia nigra, in blue here, distributes dopamine mainly to subcortical structure, and we speak of the striatum. The dorsal striatum is a striatum branched or speaking to associative areas of the cortex. The putamen is the striatum mainly devoted to sensory motor integration. So substantia nigra gives dopamine to striatum, caudate and putamen. The other big nucleus in the mesencephalon, in the ventral part of the mesencephalon, the area called ventral tegmental area, gives dopamine through the limbic system, through a mesolimbic pathways to amygdala and hippocampus, and through a mesofrontal pathways to neocortical associative area. So these are the principal dopaminergic pathways going to the forebrain. And after that, we have the cholinergic pathways, which are also disturbed in Parkinson's disease. We know that there are lesions in Alzheimer's disease, but they are also deficient in Parkinson's disease, And just a reminder of the names of the big nuclei giving acetylcholine to the rest of the brain. The nucleus basalis of Meinert is just in the basal aspect of the frontal lobe, gives acetylcholine to the cortex and to the hippocampus. And another little nucleus that's not well known from the neuropsychologists, but well known from the neurologists, is in the pons, the pedoculopontine nucleus. I speak of it, yes, because it gives acetylcholine to thalamus, and its lesion in Parkinson's and dementia with Lewy body, and it gives the vigilance aspect of the thalamus. So it's an important nucleus for vigilance. Let's go to the next slide. The late stage, as I said, is an extension of the Lewy lesions, Lewy neurites, Lewy bodies, loss of neurons in associative neocortical areas. And we speak of the occipital parietal region, parietal, temporal, and frontal associative regions. The lesions are diffuse, so the anatomopathology is identical to what we find in diffuse Lewy body dementia. And after the evolution of Parkinson's disease, which may take 15, 20 years, the brain is rarely pure Lewy synucleinopathy. There are very frequently other type of lesions reminding other type of dementia, such as senile plaques, neurofibrillary tangles, and amyloid angiopathy, like in Alzheimer's. So this late stage with diffuse cortical lesions have symptoms cognitive and behavioral, and their impact at that stage needs frequently the withdrawal of part of the dopaminergic medication that has been built up during the previous stage. The duration from the onset of the motor phase to get to the late stage is very variable, from 5 to 30 years, depending on the age at onset of the disease. Because we have patients starting at 40 and patients starting at 80, the duration of the motor phase may be short before handing to the late stage. Next slide, Arturo, please. So let's go to the, no, I have, okay. The neuropsychology of the motor phase. We have in Parkinson's disease not only motor symptoms, but also cognitive symptoms that we have discovered rather recently. Prevalence of this minimal cognitive impairment without dementia varies from, according to population studies, from 20 to 40%. The risk factors are age at onset of motor symptoms, the comorbidities, mainly vascular, which play very frequently a role in cognition, and we speak of microangiopathy, of high blood pressure, of diabetes, and the male sex. The symptoms are rather mild, but there are complaints of recent memory loss, mostly from spouse. At testing, there is an impairment in attention, working memory, the information processing speed with time tasks, executive functions, and free recall. That this free recall deficit may be corrected by contextual clues and by recognition. That makes the difference with the hippocampal type of anterograde memory deficit. This type of symptoms in neurology, we call that rather gross name of subcortical frontal cognitive deficit. Next slide. The PD-MCI can be diagnosed by very brief tools, just like the MMSE or the Montreal Cognitive Assessment, or valid instrument with a score between 24 and 30, like Alzheimer's MCI. But research has created several more sensitive tools to put in evidence more the frontal signs, the frontal assessment battery, the scales for outcome of PD, Scopacog, and the PD cognitive rating scale, PD-CRS. These scales insist on the time processing, on executive function, on proceduralization of strategies, on switching of strategies, and so on. What are the early deficits which are predictive of dementia? Mainly the word fluency deficit, and more than the word fluency, the alternating categories fluency or the action verbs fluency tasks may be more sensitive. And also visuospatial deficits are predictive of phenoconversion to dementia. Next slide. To identify an MCI in a Parkinsonian patient at first consultation has an impact on management. Some papers have studied the possibility of cognitive rehabilitation techniques in those patients, and they have been proven to help for a while. And for the neurologists, we know that the PD-MCI will be worse with anticholinergic drugs used for tremor correction. That needs a slower titration of dopaminergic drugs. And we can observe also that an excess of levodopa may increase attention problems to distractibility with more commission error on continuous performance testing of attention. That exemplifies the role of dopamine and norepinephrine in attention. Has the best attention, he's at the top of the U curve with too little dopamine and attention deficit, too much dopamine and attention deficit, but of different types. Next slide. Let's go to the motor phase. So it was not my intention to treat the motor phase and the motor aspects. I suppose that everybody knows that motor phase is mainly an asymmetrical slowness of movements with or without rest tremor and with rigidity. It diminishes the spontaneity of movements, and it's also classified in different stages. I want to speak of the neuropsychiatry of the motor phase and to detail the physiopathology of the neuropsychiatry, which is not well understood and well mastered. The physiopathology mixes some factor related to the patient, some factor context dependent, and some factor linked to the drugs that we prescribe to the patient to control motor symptoms. So this mixture of different factors renders the disease a true bio-psychosocial problem to be addressed and to be finally treated. That is usual to say that each Parkinsonian patient has its own disease because of these three factors constantly mixed in the presentation of the problem. Let's go to the next. The patient-related factor. We know that there's a genetics and epigenetics which impinges on the basic and reactive efficacy of the aminergic systems. We may draw practical inference of these genetics and epigenetics from affective, family and personal antecedents of depression or previous anxious traits or states. The personality traits and premorbid habits can give us also some cues. Next slide. The context-dependent factor is very important in the emergence of psychiatric symptoms. The psychological response of the patients and proxies to intercurrent stressors engage the same aminergic systems and have an impact on the motor symptoms and the quality of life of the patients. If a patient has a catastrophic reaction to diagnosis, if there are glooming and unrealistic projections of losses, if there is anxiety and depression in the spouse, the patient will be in a poor motor state and the needs of dopaminergic therapy will be higher. So the physician attitude, the education, even the treatment of the spouse if she's depressed or he is depressed, and the usage of cognitive behavioral therapy for the patients has been shown to reduce anxiety. Next slide. The drug, dopaminergic replacement therapy factor, the drug factor. Motor symptoms of Parkinson's disease improve with dopaminergic replacement therapy. We know that bradykinesia, rigidity, tremor are easily controlled during an average of 5 years. We call that period the honeymoon period. After a while, levodopa, which is the main drug used in those patients, the gold standard of treatment, depending on high dosages and duration of treatment, is associated with motor fluctuations. That means that the effect of the dose of L-dopa will be shortened with time. There is wearing off, disappearance of the effect, and pluri-daily alternance of on state, where the patient is controlled, and off state, where Parkinsonian symptoms reappear. We can observe an excess of movement that we call dyskinesia in on state, when the L-dopa dose is efficient, and other types of abnormal movement called dystonia in a off state. And more, we have non-motor symptoms fluctuations. That means that if the patient is anxious or depressed, we may observe short period of dysphoria depending on the alternance of on and off states. Next slide. Just a reminder of the different type of drugs that we get to control tremor. We use anticholinergic, trioxyphenidyl, lorphinatrine. To control for akinesia, we mainly use L-DOPA, which is transformed by dopaminergic and serotoninergic neurons into dopamine. To have an effect on dopamine receptor, we use dopaminergic agonist, here bromocriptine, it's an old slide. And there are ways of retarding, delaying degradation of dopamine with monoamino oxidase B, such as selegiline and rasagiline. And at the periphery, before entering into the brain, we have the catechol-O-methyl transferase inhibitors, such as entacapone or tolcapone. Next slide. The drug factor, the dopamine replacement therapy factor. We have the problem of possibly overdose the mesofrontal system and progressively sensitize the mesolimbic pathways with our drugs. So overdosing and progressive sensitization of mesofrontal and mesolimbic dopaminergic pathways are an active factor in the development of hallucination, perceptual problems, cognitive problems, and behavioral problems when we try as neurologists to balance the dose to control for motor symptoms. Next slide. Let's go to the presentation of these problems. The whole catalog of psychiatric disease may be found. Affective disorders, depression and manic disorders, anxious disorders, psychotic disorders, with the 3 types that I will detail, and goal-directed behavior disturbances. Next slide. For affective disorders, the main problem is depression in Parkinson's disease, which has been really underestimated. The prevalence, in fact, 30% of patients will have a long-lasting depression deserving treatment during their career of Parkinsonian patients. In a cross-sectional study, we find usually 20% of major depression criteria and 30% of subsyndromal subchronic dysthymia. The risk factor, as always, for depression, female sex, young age onset, family and personal antecedent of depression, and curiously, higher dose of L-DOPA. The presentation can be inaugural, even a little bit before the appearance of motor symptoms. It can be reactive to diagnostic. It can be associated with motor fluctuation developing when appear the motor fluctuations. It can be later mixed with cognitive impairment and apathy, or it can be short-term during this half state, which may come many times a day at the end of the effect of each dose of L-DOPA. Or it can be acute, and that's an interesting fact that has been put in evidence with the deep brain stimulation of the subthalamic nucleus, which appears to be a node in the mood circuitry. So all these type of the presentation of affective problems, short, long duration, deserve attention. Next slide. The diagnosis can be made with regular checking with brief instruments like the geriatric depression scale with a cutoff score of 5, or the Beck depression inventory with a cutoff score of 18. Dimensional analysis of the Beck depression inventory items may be useful for the choice of antidepressant in a Parkinsonian patients. The BDI items can be categorized into hypokinetic items such as loss of interest, fatigue, loss of energy, indecisiveness, excess of sleep, loss of appetite for food, for sex, and hyperkinetic items, which deal with the intrusion of the sadness, pessimism, the worthlessness and guilt, the suicidality, the internal agitation, the irritability, and the sleep disturbance with loss of sleep, with initial and late night insomnia. To distinguish these two factors is important because you can increase symptoms of the hypokinetic items with an SSRI, a selective serotonin reuptake inhibitor, while you can treat the hypokinetic items with the dopaminergic drugs or a dual norepinephrine serotonin reuptake inhibitor. So it may be interesting to try to decipher a little bit the items that we collect in inventories. Next slide. Manic disorders in Parkinson's disease is rare, but it's always a problem of overdosing of dopaminergic drugs or too fast titration. The risk factor for sure is bipolar disorders in the family. Problems with thyroid may give some excessive response to dopaminergic therapy. Covered drugs, I have some patients with ginseng formula coming from China, which get into minor manic state and young age at onset. The presentation is manic, inappropriate elation, flight of ideas, logorrhea in on state, absolute reduction of sleep, impulsive decision-making, impulse control disorders. The impact on management is attention to drug withdrawal depression. Next slide. Anxious disorders. Some recent papers insist on anxiety because in fact, I would say that all my patients have anxiety phases and some stay anxious. The prevalence in studies is high, more than 40% of patients. The risk factor, like for depression, is female sex. And the presentation is proteiform, just like generalized anxiety disorders, obsessive compulsive disorders, phobia, specific or not, panic in off state, which may be real panic states, patients getting the impression of dying very soon or being closed or to faint, or it's really panic which leads the patient to a hospital. This anxiety may be the cause and consequence of sleep problems with heightened arousal. And heightened arousal may be a consequence of too much L-dopa. This anxiety may be the cause and consequences of motor complication, such as unpredictability of offs. The patient doesn't know if the dose will be efficient or not, and lives in the anxiety of the off period. Acuteness of off periods are seen when the patient is anxious, and some problems specific to Parkinson's, the freezing of gait. Patients cannot initiate gait. He is frozen on the, it can be a result of a panic attack. Next slide. Anxiety has to be dealt with, at least with some attention of the physician, and eventually with therapy, psychological therapy. We have to prevent absolutely the deep fluctuations of motor states, which are the cause of an anxiety, of anticipation of off. SSRIs for generalized anxiety disorder for patients with premorbid anxious traits have to be added to the regimen. If from time to time, low-dose dopaminergic agonists, as in restless leg syndrome in anxiety, where internal agitation and initial insomnia are predominant, may be a treatment for that. Next slide. Psychotic disorders. The prevalence, at least 10% of patients before dopaminergic drugs may have the visual or synesthetic hallucination or vivid dreaming. That means that with the dopaminergic deafferentation, patients may have sensitized D2 receptors and hallucination. On treatment, 15% of treated patients may have hallucinations. The risk factors is the female sex, old age at onset, dopamine replacement drugs, and drug interaction. We have 3 big types of psychosis: the benign or isolated hallucinations, the paranoid psychosis, and the rare but difficult to treat catatonic cycles. Next slide. The isolated hallucinosis is well known. Its main risk factor is a peripheral sensory deficit, since only retinal problems can give some hallucinations, but retinal problems plus dopaminergic drugs may present with not frightening, well-criticized visual hallucinations of animal or persons in type for the same patient who always sees a dog in his bed or in some trees, or persons in the trees at the window. And frequently olfactive or synesthesics, that means sensory hallucinations or illusion of spider thread or caress on face and hands. This isolated hallucinosis has an interesting physiopathology, and an hypothesis has been described by Isabelle Arneuf, who is a specialist for sleep in La Salpêtrière. That could be due to cholinergic pontine denervation. The pedunculopontine nucleus is a nucleus important in dreaming, with some norepinephrinergic nuclei of the brainstem. And these hallucinations could be REM sleep phenomena erupting into wakefulness. The imagery, oniric imagery, erupting into wakefulness. The impact of management. We know that these patients will lack of acetylcholine, so we can't treat them with anticholinergic, and we have to search for anticholinergic drugs added by other therapists. We may try cholinesterase inhibitors, even if there is no studies on that, it may work. And if this hallucinosis is rapidly flourishing, we have to change diagnostic from Parkinson's disease to dementia with Lewy body. Next slide. Paranoid psychosis. The risk factors are untreated depression and supportive environment, intercurrent distressing event, and hidden drugs potentializing dopaminergic replacement therapy. The presentation is a classical paranoid psychosis with delusion mainly of the persecutory types, delusion of thefts, cheating of the spouse, abandons, threats. There is an abnormal perception of presence in home and frequently hallucinations of persons at night, visual hallucinations, but also auditory hallucinations congruent with depressed mood. And there is a constant poor sleep, sleep disorders with restlessness, agitation, confusion, and hallucinations at night. Next slide. The impact of management. In fact, this is mainly a prevention problem. We have to regularly check a psychosis checklist. Do you have hallucinations at night? Do you see persons or animals? Does it obvious for you that there is somebody in the room or at home? Or do you have the impression of having somebody behind your shoulders? The sleep and change of behavior has to be checked with the caregiver. Protection of sleep quality is the main prevention. Treat insomnia, and I give some receipt there of mirtazapine and quetiapine. The treatment of paranoid psychosis, it's not a good choice to hospitalize because it will make flourish the delusion. Avoid drastic change of environment and caregivers. Withdraw as much as dopaminergic drugs as you can in the following orders. Anticholinergics first, selegiline, the inhibitor of monoamine oxidase, amantadine, dopaminergic agonists such as ropinirole, pramipexole, icons such as tolcapone and tacapone, and introduce among atypical neuroleptics only quetiapine, clozapine, and pimavanserin. All the other atypicals may increase Parkinsonism. So pimavanserin is a very recently launched drug which has only one indication, Parkinson's paranoid psychosis or dopatoxic psychosis, but there is currently a hold on because there are a lot of deaths in the follow-up of post-marketing, post-launching drug. Let's go to the next slide. Catatonic psychosis, the prevalence is rare but potentially lethal, and it may be a problem of handle function of the brain stimulation. The risk factors, family history of affective disorders, rapid changes of drugs acting on dopamine or serotonin, major changes in the environment, and frequently thyroid or electrolyte or septic abnormalities. The presentation is negativism, hyperrigid fixed postures, hypervigilance, and sleep deprivation. And the treatment, like other catatonic cycles, is benzos, eventually intravenous, and L-DOPA, eventually intragastric, and electroshock therapy. Next slide. The last neuropsychiatric problems which we can observe in our patients are what I call goal-directed behavioral disturbance. They are neglected by patients, reported by proxies only. They have to be searched for because they are potentially devastating. 4 sections in that category of behavioral disturbances: apathy, impulsive control disorder, or ICD, pending, and dopamine dysregulation disorder. Next slide. Apathy. There are at least 3 scales of apathy validated in Parkinson's disease, 2 by the authors quoted here. The prevalence is high, but it's under-treated or under-considered because it's mostly mixed with depression or dementia. It can be as high as 40% of patients, and is more disturbing for the caregiver than for the patients. The impact on management, there are very few control studies, if only there are 3 scales for apathy in Parkinson's disease. And we are generally trying drugs without knowing titration and dosage of psychostimulants or dual norepinephrine and dopamine reuptake inhibitors, or an allele modafinil, which is a drug used in somnolence and narcolepsy. And we try to externally structure the behavior of the patients. Next slide. Impulse control disorders has been the topic of high research during the 5 recent years. Prevalence may be as high as 20% of patients. The risk factor are premorbid drug or behavioral addiction. And we have young patients starting their Parkinson's disease at 40 who have been pre-exposed to cocaine or methamphetamine. Risk-taking personality profile, which is not the most frequent profile in Parkinson's disease, but which exists. Male sex, and our treatment, once again, the dopaminergic agonists that we use because they stimulate mainly D2 and D3 receptors, and the D3 receptors is more abundant in the limbic striatum, nucleus accumbens septi. The presentation of these ICDs and overinvestment out of reason in activities such as sex, with deviant sex, gambling, too costly gambling, eating, such as in eating disorders, or shopping. But it may be also an overinvestment more useful, such as creative activities. And I have patients who went to painting all nights and made a big exhibition of their paintings very quickly. Hobbies and Samaritanism, which means that the patient is wasting money just for the sake of giving gifts to others. To make a diagnosis of ICD, you have deleterious consequences to impact on the social, professional, and family life to make the psychiatric diagnosis. And the patient knows that there are deleterious consequences to his acts, but can't get rid of them and neglect them. So there are some questionnaire for impulsive compulsive disorders in PD, which has been developed by Weintraub, the QUIP, and it can score mild, moderate, or severe type of impulse control disorders and follow an intervention. Next slide. The detection of this problem is a real problem, as patients often deny the problem, and the correction is a real problem, as deleterious consequences of this change in habit may have already occurred in family and work environment. Treatment is slow withdrawal of the dopaminergic agonists, which are the main culprits, and there is a high risk of withdrawal depression needing a tight psychological support. Next slide. Wounding is another curiosity that we may observe in our patients. The definition is stereotypical repetition of the same arrangement, disarrangement behavior without goal realization. It's an erratic repetition of the same sterile behavior. It has been first described in amphetamine addicts, and it resembles some experimental observations in animals. The risk factor are PD and CI, and an overdose of represented by peak dose dyskinesia in on state. And the presentation is an endless activities of displacement, rearrangements of things in the house, in the kitchen or in the garage, without urge, without anxiety, and described by the patients as soothing or diverting. The treatment is a reduction of the peak dose of L-DOPA by dose fractionation. Next slide. Dopamine dysregulation syndrome is also a curiosity, but even it's rare, it's difficult to treat. Risk factors are male sex, young age at onset, premorbid opioid or cocaine exposure, which have launched or primed the dopaminergic system. The presentation is a genuine addiction to L-DOPA with craving phenomenon, dysphoria, aggressiveness, inappropriate behavior in order to get a higher amount of drug, compulsive intake of multiple L-DOPA doses beyond the number required to control the motor slowness, which may induce unpredictability of L-DOPA dose and dose effect failures. The impact on management is urinary and hospitalization, and a tight, close hospitalization because the patients want to get out, and from time to time transition to a more continuous way of giving L-DOPA, like intrajejunal continuous delivery of L-DOPA or surgery with deep brain stimulation. Next slide. Now that we have seen all the problems during the motor phase, let's go to the advanced phase, the extended Lewy bodies in cortical areas, and we arrive to Parkinson's disease dementia. Prevalence, which was recognized as 30% before by neurologists, has eaten, maybe because we have studied quite carefully that stage, to 80% Parkinson in patients in long-term facilities. The diagnosis criteria means that we have to get a history of Parkinson's disease of more than 1 year, and we'll see why. Impairments of the activity of daily living are not attributable to motor handicap, but to cognitive handicap. There is an impaired cognition in the range of dementia, multi-domain, and there are behavioral, perceptual, dysautonomic, sleep wakefulness disturbances that we don't have in other type of dementia. I speak of Alzheimer's. So hallucination, orthostatic hypotension, nocturia, diurnal somnolence, nocturnal agitation are part of the cognitive or associated to the cognitive problems. Next slide. Artificially, maybe we have distinguished the diagnostic criteria from diffuse Lewy body dementia by her history of cognitive perceptual disturbances for more than 1 year before the appearance of motor symptoms. So the dementing disorder is the same, but not the same chronology. The main feature is slightly different. The first symptoms which attract attention are hallucination, complex and variable visual hallucinations, maybe frightening, and fluctuations of the level of vigilance, many times during the day, from confusion to normality. Suggestive and supportive features are the same, slightly different than in advanced Parkinson's disease. REM sleep behavior disorders is important. Neuroleptic sensitivities, that means that our patients may become quasi-stuporous or heavily sedated with, or heavily Parkinsonian with neuroleptics. Dysautonomic problems, falls and syncopes, transient stupor without drugs. And there are differences with Alzheimer's, which is the decreased occipital uptake with PET or SPECT findings. Next slide. Finally, Parkinson's disease dementia, diffuse Lewy bodies dementia, and dementia of the Alzheimer's type with comorbid cerebrovascular disease may be difficult to differentiate, especially in the absence of a good history. A neuropsychological battery may make the difference, but not always. Currently, that's not much important since cholinesterase inhibitors are given in all 3 diagnoses after studies with these drugs. But imagery with PET tracers of beta amyloid, of tau, and CSF or cerebrospinal fluid biomarkers are a field of intense research to determine parameters of efficacy and select patients for vaccination trials. Next slide, the end. My conclusion is that PD is the second most common neurodegenerative disease after Alzheimer's disease, so we have interest in knowing the range of cognitive and neuropsychiatric disturbance that we can get with this. The connective impairment is associated to well-known motor symptoms, illustrate the role of dopamine in attention, working memory, and executive functions. And the range of neuropsychiatric disturbances partially related to the dopaminergic treatment has a major impact on quality of life and eventually institutional placement in long-term facilities. And it shows the role of dopamine in mood regulation, sensory integration, and the independence of behavior from the context. That means that the behavior to be independent, not to be reflexive to the context, to be goal director needs a good balance in dopamine. So that was my conclusion. And the next slide is just to say muchas gracias. Gracias por la atención. I'm ready for questions or comments.
Okay, thank you very much, Doctor. I don't know if we have some questions. Si tenemos preguntas.
Hay una aquí en el chat, Ron.
Okay.
¿Se la traduces tú o...?
Sí, nada más que no sé cómo...
Okay. Si quieres quitar la presentación y ya nos quedamos hablando nosotros y yo le puedo leer la pregunta a la doctora. Doctor Pourcher, es una pregunta, a question of Daniel Millán. He says that, what is your opinion about amantadine in the beginnings of Parkinson's disease?
Okay, it's a question of treatment. Amantadine is interesting at every stages of Parkinson's disease. It can be used to control a little bit of rigidity and akinesia, much less than L-DOPA. It can be used to control dyskinesia, peak dose dyskinesia, when has developed a motor fluctuation with an excess of movements in on state. And it has been also used just for impulse control disorders when we try to lower the dopaminergic agonist and to control for the impulse control disorder without depression, when we withdraw dopaminergic agonist. So it's an excellent drug and also an antiviral drug.
That is correct. Okay, maybe while someone else asks a question, I do have one. Of course, I would like to thank you for sharing with us. And of course, Parkinson's disease does not get the attention, for example, as Alzheimer's disease. And I think the most common association people have with Parkinson's disease is tremor. But what you have shown us today is that it also has some consequences in the affective area, behavioral area, such as depression, manic disorders, anxiety, etc. So I know that this is maybe an unfair question, but in a broad range, what would you consider are the best therapeutic courses for addressing these peripheral symptoms like affective and behavioral? Is it on the shoulders of psychiatry, or do you have an idea of some other courses of action?
That's a hard question because neurologists get rid usually of psychiatry to psychiatrists. Mm-hmm. But as you have learned from my presentation, we as neurologists try to control motor symptoms with drug recipe which may have an impact and create psychiatric diagnosis. And the psychiatrist which is asked in consultation will have some problems to correct these symptoms linked to treatment. So there has to be a good team between psychiatry and neurology to fine-tune the treatment of the patients, not at the expense of the motor status, but to treat correctly all the problems linked to overdose and sensitization. But the psychiatrist may enter in the role of the psychiatrist is to consider depression and anxiety because we are undersensitive to depression and anxiety in neurology. Maybe you as geriatricians are more sensitive to that in older patients, but and we follow our patients from semi-old to old without considering those aspects. And they terminate their career with a lot of drugs for moving, but with psychological and even social, the impact on the spouse is very important with different problems that the neurologist doesn't take in charge very frequently. So if I have understood right your question, what would be the exact, what was your question, Gustavo? What was your question finally?
Yeah, well, it was, if it in broad ranges, what were the best therapeutic courses for addressing the peripheral symptoms? Because of course, you talked about depression and anxiety and some other behavioral issues. And of course, this is not a regular depression or not a regular anxiety disorder. It is.
No, that's not regular. That's not really the, we call them psychiatric diagnosis, and we have to use the psychiatric terminology, but the context is very different. In fact, it can be iatrogenic, in fact. And to approach this is to know that there is some problem with dopamine. The interest of that is that we have learned the functions of dopamine in cognition and in affect with Parkinson's disease, which is a kind of exemplary disease. It's a neuropsychiatric disease, a Parkinson's disease. And the main, I don't know if it's well approached in psychiatry better than in neurology or better than in geriatry, because all these patients get older with dementia and behavioral problems. But no, the courses of, so to study that correctly is in fact, I don't know how to answer your question, Gustavo. In what type of course you may approach of that? In my lecture, what?
Sorry. No, well, it was an overarching question around your expertise. But I consider myself satisfied with the question you have already answered.
Oh, thank you. But I wonder if I've rightly understood your question, Gustavo. What course? Yeah. Yeah. Okay, let's go.
Okay.
I have another question. I know that a doctor called Antoine Lutz, I don't know if my pronunciation is okay, but he works in the Lyon University at Lyon in France, and he is doing some working with meditation in older adults. And I don't know if meditation, it's becoming like a trend. It's popular with the time. And I don't know if there are studies or background about how meditation can help these affective, maybe, and the affective symptoms associated with Parkinson's disease. Do you know something about that?
Yeah, yes, that's a good question. I've not spoken about non-pharmacological interventions, but anxiety and the high level of stress, of worriness of our patients is approachable through non-pharmacological interventions. And there are studies with méditation, pleine conscience, there are studies with cognitive behavioral therapy and anxiety features. There are studies with yoga, and all this, which has been proven useful in non-Parkinsonian anxious patients, is useful in Parkinsonian patients. The studies are less obvious because it's always difficult to have a true placebo condition, true intervention in those studies, but usually patients improve. And treating anxiety and addressing anxiety and stress in our patients is really paying in terms of diminishing the level of drugs to control motor symptoms. That's this interaction between anxiety and the effect of drug that is the really the astonishing in Parkinson's disease, where anxiety goes into motion. It's very obvious in our patients after a while, after a period of treatment, that dopaminergic drugs may induce anxiety, and treating anxiety may allow us to decrease dopaminergic drugs.
Thank you very much. I think we have two questions from the public. The first is from Maribel Romo, and she asked, what's the impact in the patient with not only the medicine part, the drugs part, but also the neuropsychology? What's the impact of the mix of the neuropsychology aspect to the treatment of this kind of patients?
So maybe I didn't insist enough, but the psychological part and the approach, the psychosocial approach of the Parkinsonian patients is very important. The psychological part or reaction of the patient will engage the same neurotransmitters. So some psychological negative reaction may increase the motor aspect of the disease. I in fact repeat myself with that interaction. I consider that the psychology of Parkinson's patient, of the Parkinsonian patient, has to be taken in charge with specific approach. And there are very few psychologists dealing really with Parkinson's disease, but as I underline, each patient makes his own disease and has its own environment and has a different style of coping, and the spouse may have a different style of coping. So the psychological intervention and support is very important. And we have the need of a psychological team that in neurology is really lacking. And we are more approaching now Parkinson's disease in multi-integrated aspects of treating psychological aspects, physiotherapeutic aspects, and so on and so on. I am a neurologist. I prescribe drugs, so I have insisted upon my field, but psychology, the question is it important? Yes, it's important. If we have psychological support from the beginning, the disease will be more tolerated, but even less important.
Thank you very much. I think we have two more answers. Questions. The first one is, if we notice the similarities between Parkinson and Alzheimer, is there a connection, or what will be the connection if there is one between these two diseases, Parkinson and Alzheimer?
Well, as I said, there are the main problems of aging in our westernized countries. They lead to dementia, not in the same pattern of evolution, but frequently Parkinson's disease comes to dementia. The lesions and the type of abnormal protein which lead to neuronal death, they are not the same. They are not the same localization, and they are not the same type of abnormal proteins. Eventually, they touch the same circuitries, the circuits of the memory, the circuits of interpreting our environment, the circuits which make us independent from the context to behave. So we are demented, yes, in Alzheimer's and Parkinson's, but not with the same lesions. But we treat the same because the circuits finally, at the end of each disease, are the same. And we treat with the same drugs, enhancing acetylcholine. And the approach of the behavioral problems are the same also. And they have also both behavioral disorders that I have not quoted in Alzheimer's, but very similar, but not in the same evolution pattern. So there are differences, there are commonalities. We treat with the same drugs, but behavioral problems are slightly different. Is it okay?
Thank you very much. We have another question. This one is from Eduardo Castillo, and he says, hello, doctor. Recently, there has been a breakthrough in the discovery of Parkinson's disease biomarker associated with odor in the sebum secret on the upper back. What's your opinion about the foreseeable future with this finding? What's the next step?
I heard or I understood till biomarkers.
Yes.
So there are a lot of biomarkers, and I ended my lecture on the biomarkers that we can identify in CSF, in the cerebrospinal fluid, and the markers that can be identified with the imagery, with the PET scans. In Parkinson's disease, there are markers in the CSF, such as alpha-synuclein, and in demented Parkinsonian patients, there are also the same biomarkers that we have in Alzheimer's disease, so beta-amyloid and phospho-tau. These are important things if you want to approach the disease by vaccinating patients to decrease the accumulation of misfolded proteins which make lesions. Alpha-synuclein is the main culprit in Parkinson's patients, and there are already vaccination strategies to decrease alpha-synuclein accumulation. So these are major breakthroughs, that's right. These are all experimental trials and data. We miss real biomarkers to follow interventions because alpha-synuclein is abnormal, but not in a proportion that we may follow during the evolution of one individual patient or even a group of patients. So Was it exactly the question, or is it
I don't know if I understand right the question, but if it's possible that Eduardo Castillo activate his microphone.
If I may.
Yes.
Okay. Well, the question was more, what I wanted to ask is, what is the next step with this finding? Because when I read the article, the first thing that sprung into my mind was, why don't we train docs to maybe do a quick screening in underdeveloped countries, if this is of any use. But I don't know if there are any other ideas that might, that we can bring this finding to another level and maybe help with the diagnosis, or yeah, with the early diagnosis to.
What was the finding? What was the biomarker that was in that paper?
I can give you the article through one of our teachers here. I don't remember, I don't have it with me right now, I don't remember the specific biomarker, but it seems that they discovered it in the upper back, in the cerebellum.
In the upper back of the brain?
No, the back, your back, the
upper back.
Yeah, the espalda.
In the spinal cord?
No, on the skin.
On the skin. Oh.
Yeah.
Oh.
So.
I'm not really aware of that paper, but there are some markers in the skin. We can eventually find synuclein deposit in the skin, but also in salivary glands, and also in mucosae of the stomach, of the esophagus, of the colon. So synuclein deposits is elsewhere in different tissues, and even eventually may propagate through blood. So we are always dealing with alpha-synuclein, but now it's everywhere. And eventually it can be a diagnosis, an early diagnosis tool, but this is too early. And there are lots of variability in the sensitivity of these different techniques. They are not homogenized from one group to the other who published.
Oh, okay, I see. Thank you very much for your answers.
Sorry, I think we are on time. If we don't have another question, the next step is thank you very much, Professor Emanuelle, for being with us and for sharing with us a lot of very interesting information. I think we all may have the big picture about different areas of what implies Parkinson's disease, symptoms, some medical treatments, etc. Thank you very much, and we hope all the students enjoy the lecture as we did. And it's nice to know you and to know a little of your work. I don't know if Dr. Gustavo have some words, but I think it will be the last thing.
If you have more questions, you may send it to me or come back with an email. Arturo, give some details. I realize that I've been very biologic and maybe it didn't cover all the curiosity of your audience, but if there are further questions, you may send them to me by email.
Thank you.
Well, thank you very much, Dr. Emanuelle Pourcher, for being with us and for being so generous and sharing with us your knowledge. Of course, we will take your word, and if we have any more questions, we will make sure to get them to you. And I hope that this occasion is not the only time that we're going to share with you. So we hope to see you again at CETYS, maybe next time in person. So
yeah, for sure. Thank you. It was an honor for me. It was really a pleasure for me. And sincerely sorry not to be able to give a speech in Spanish. Muchas gracias.
Muchas gracias a usted. Y bueno, muchas gracias a toda la gente que nos estuvo acompañando el día de hoy en Zoom y en Facebook. Y bueno, les damos un agradecimiento de parte de las maestrías en Neuropsicología y en Gerontología Social. La próxima semana tampoco se vayan a perder la siguiente conferencia que tenemos. La información estará en Facebook. Y bueno, bienvenidos y gracias por acompañarnos el día de hoy. Y de nuevo, gracias a la doctora Emanuelle y gracias al doctor Arturo Ron por gestionar todo el evento y por conducirlo. Y bueno, pues eso es todo por el día de hoy. Muchas gracias y hasta luego.